this happens every day, but it also comes up in the exam. It's something that we as emergency physicians have to be able to do really well. So I guess the difficulty with these cases is you have your agenda.
It's a mismatch between agendas.
And the nurse came and found me and said, "Look, she's keen to go home. She doesn't want to wait for the scan." We're talking about patients who want to discharge against medical advice.
Hi, it's Jonathan.
Hi, it's Jana.
And this is Cut to the Case. So Jana, how's things?
Yeah, good, thanks. Yeah.
What are we talking about today?
Well, today I thought we'd talk about a case that I had recently of a patient who wanted to DAMA, which is discharge against medical advice.
Yes, there's a lot of that going on actually.
Yeah, it's not surprising with how busy everything is.
It's so busy, you know, and I get it, people don't want to wait. People have other things to do. They turn up to hospital hoping for a kind of outcome, and then maybe they don't get the outcome that they thought. So they think, well, maybe I'll just leave. Maybe it was just a quick, I need some antibiotics, go home.
Yeah.
No, we want you to stay. So what happened?
So it was a woman who was in quite a high-speed car accident. It was over 70, 80 kilometers an hour and didn't have many signs of injury, serious injury.
Like
however,
high
with that,
thing.
but with that mechanism, you worry about injury in the chest, and at the very least, we wanted to get a CT of her chest, which she was agreeable to. She was also pregnant, I should add, as well.
All right.
And the nurse came and found me and said, "Look, she's keen to go home." And then we had a conversation, and she left.
How pregnant was she, can I ask?
About 27, 28 weeks.
All right, yeah. So viable pregnancy, potentially 2 patients.
Yeah.
So what happened? Tell me what happened.
So what happened? So I had to go and have this conversation with her to do my job, which is to try and advocate for the best care for her, which in my opinion at the time was to stay and at least have some further observation and have this scan. She'd also been seen by the trauma team who wanted further scans as well. So we were actually planning to scan her whole body. And I guess the difficulty with these cases is you have your agenda and you really need to make it happen, and you've got all these things that you need to tick off your list to sort your patient out, but you also have to remember that patients have commitments and lives outside of
I'm thinking about what I think it's a mismatch between agendas, and I think this is what we see a lot. We need to impress on the patient, what we're worried about, what our agenda is, and I guess if we don't, then that's probably our thing we're not doing right, I guess.
And it's hard because this happens every day, but it also comes up in the exam, and so it's something that we as emergency physicians have to be able to do really well. So it happens all the time in all types of presentations and patient demographics. So
what's your step-by-step approach, Jana? You must have one.
I do.
I think you do.
For an exam approach, and in real life approach. I think you need to think about the medical aspect of it, and why it is you want that patient to stay. Then you need to think about the patient factors as well. So objectively, the patient needs to stay for this test, this treatment, this plan for observation, whatever it is, and you need to impress that onto the patient and explain in language they can understand why that's important. A lot of people are afraid to use the word, you might die, but sometimes you have to say that because they can't make that decision if they don't know the consequences of the decision.
And I guess people think that, well, maybe the healthcare system is so good that if I do come back, I will be okay, and they'll patch me up. But actually, it's not always the case, right? So we're really worried that they might actually die or come to major harm if we don't intervene right now. And we're worried that if you leave it for a bit longer, then it's going to be unsalvageable. That's what I think about. So you talk about the medical stuff, impress that with her, and then what's
so
the
you
other stuff?
talk about the medical stuff, and then once you've said your piece, as it were, then it's time to have a conversation. And what you're doing in that conversation is you're exploring the reasons why they want to leave, and you're looking for possible solutions. And what you have to do, and this is important for the exam, is you have to think about the patient as a whole and cover all the aspects of their history. What's their social history? What do they do for work? Who's at home? Are they looking after somebody who's fully dependent on them? and try and problem solve that as best you can. But the overarching thing that's occurring is you're assessing your patient's ability to make this decision, because
so
sometimes
that sounds like capacity assessment of some kind. Yeah.
Because sometimes, say in trauma, for example, they might be head injured, they might be drug affected, and maybe they don't have the ability to make that decision, and you have a responsibility to, you know, keep them in hospital, to advocate and get them the care that they need.
Yep.
That's a rare situation, but it does happen, doesn't it?
So we impress our reasons for needing to stay. We explore their side of things, if you like. What is it that they need to go home for? What, you know, what is the issue? And hopefully come to some ground. If you are making that capacity assessment, what are the key points in that capacity assessment?
So the key points is that they have to be able to understand what you're telling them. So that's number one. They need to be able to understand the consequences of their decision to go home, and they have to be able to repeat that back to you. And those are the main components, I think, of capacity assessment.
Why is repeating back so important?
Because it shows retention and that they understand.
They remember it.
They remember it, and they can understand the impact of that decision.
It's kind of gone in and locked in. They've actually maybe processed it. They haven't just gone, no, whatever you say, I just want to go. It's kind of not good enough, is it?
Yeah.
You really have to retain it. Yes, I understand what you said to me. Repeat it back, I guess. And here are the reasons why. Anything else to it?
I think you have to also figure out what their reasons are for leaving, and see if those are reasons that are, you know, because sometimes you could have patients who have mental health problems, who have a psychosis, and those reasons might actually be a part of that illness. And so it's really important to really explore with the patient why it is they need to leave, and not cut that short. Yeah,
that's the problem solving part, isn't it? Because we're in this situation every day, but the patient might only be in this situation once or twice in their life. So we're in this situation, we go, actually there are ways around all these things that we find for other people every day. You know, like someone can go and feed the dog, or someone can go and do this thing for you, or actually you know, you can, we can get you back tomorrow. It is possible. We understand the system. I'm the agent for you, and I can tell you how the system works. Or the reason you need to stay is because the system works this way. If you go home, you can't come back for the operation tomorrow because you'll lose your spot. In the list, right? So people don't necessarily know that.
It's hard, and it doesn't. It's not always true, right? Because sometimes we can send people home and they can come back and have the plastic surgery the next day, and they don't have to stay in it. So it is variable.
Variable is the thing, I think.
And so then, so you've done your capacity assessment. You've explored the reasons why they want to leave, and you're trying to problem solve it, and you've delivered all the information you need to. And they still want to leave, then what do we do?
Well, do you go and cry in the corner like you're a failure? You haven't,
it feels like a fail. It feels like you failed, because actually what has happened is we have failed in a sense, especially with how busy everything is. We've failed to deliver that care in a time that is, you know, appropriate for them, or what they would deem appropriate for their life, you know, or, you know, their needs. So in a way, they feel like we failed them, and so you kind of have to acknowledge that as well. And then my next step is, okay, I've tried everything in my arsenal to get you to stay. How can I make this situation as safe as possible? So that's like facilitating as safe possible.
So it's a harm minimization approach. So you're going to go, but okay, got it. We're not changing that. You're going. But here's how I can help it so that you'll have less harm when you leave.
So that could look like, okay, let's get you, I'll book you a rapid access clinic appointment next week. Or make an appointment with your GP in the next 2 days. I'm going to write a plan out for them to repeat this blood test, or, you know, to organize this, you know, this investigation. Or why don't you come back tomorrow? We'll do the ultrasound tomorrow as an outpatient, and we'll. Do you ever
get resentful doing that? I mean, it's more work.
It is more work. It is more work. But then I think about my life at the moment with small kids, and I think, gosh, it would be so frustrating waiting for something that, like, you know, if you're waiting, how long you have to wait for a scan?
That's what
and if you're not urgent, you just get bump, and you know it's going to be normal because you feel well in yourself, and they often are, like, fine, aren't they? But we're becoming.
I've just realised something. So I've been admitted to hospital twice. Both times I'd done it. Both times I did, because you know what? I felt okay. What they did was done. They wanted to keep me for a reason that I thought, well, I don't need it. And I left. I'm the worst patient ever.
So there you go. But we all have lives, and we all have things to do, and nobody wants to sit in an ED if you're feeling not too bad and you don't want to be there. What is the problem. We're worried about bad outcomes and what that would mean for us.
Yes.
I think as well. So
and
I think
I
think that's part of it. We want to give the best care, but also I would be worried if someone left without a scan and I've missed something, and then something bad happens to them. So
what I mean by the outcome for the system, if someone has to then come back again the next day, then that's a whole lot more work that's now generated on the system. So because they get worked up again, the history happens again, all that. It won't be you seeing them again. And then there's this whole repetition thing that people don't necessarily realise either. So there's another chunk of work, which means another person has to wait, which just compounds the problem of people waiting. So it's a tricky thing.
It's really hard.
But I think you've nailed it, Jana. So let's wrap it up. So summary, what are we doing?
So what we're doing is we're talking about patients who want to discharge against medical advice, so like halfway through their care in the ED. And so a good approach is, would be good for your exam as well, is to think about, a capacity assessment. So are they able to make that decision, conveying to them the medical reasons why you want them to stay and the potential complications or harm that could come to them if they leave before you complete their care. Make sure they can repeat that back to you and understand the weight of that decision. And then if all else fails, well, actually you're going to do the problem solving bit while you're doing that. So
it's actually
why do you want to leave? Is it childcare? Is it feeding a dog? Is it, is it work? And if all else fails, then do everything you can to facilitate. Don't just throw in the towel and go, well, that's your decision. But I think we still have a responsibility to make it as safe as possible.
Minimise harm, because we know that that's the whole reason why we wanted them to stay, so they didn't have any harm. And I guess finally it's documented, isn't it?
Document everything.
So that people understand. The next person down the track understands what
it's good for to protect yourself, but also it's invaluable to the person who will then look after that patient if they do represent, and they know what's been discussed, they know where you got up to in your treatment or your investigation plan, and it makes it easier for everybody.
They can just pick up where you left off. Okay. Well, thanks, Jana. That was great. That's DAMA, Discharge Against Medical Advice. A pregnant lady, and that's a bit of a segue about something that's coming, isn't it?
So we're doing a course on obstetric trauma soon, and so I thought a good thing we could discuss is how we talk to our pregnant patients about radiation in the emergency department.
Because that's something that
it's a very difficult conversation.
So let's save that for next time.
Okay.
All right, see you everyone.
See ya.
Bye.